So coming on to the mitral valve now, the mitral valve, of course, separates the left ventricle from the left atrium, and it can leak due to rupture of chordae. The chordae, of course, supports the leaflets, or if they're not ruptured, it can elongate so that the two leaflets do not close at the same position. This can cause mitral regurgitation, or the leaflets may be too big, what we call myxomatous disease or Barlow's disease. So if the leaflets are too big in size, they don't close properly, and this can be a cause of mitral regurgitation. Mitral regurgitation can also be functional, where the heart is dilated and this pulls the mitral valve apart, so it doesn't close. So this is a 64-year-old lady. She had complained of increasing shortness of breath. There was a loud pansystolic murmur in the mitral area. Heart valve disease is actually a condition which you can all diagnose in your clinic just by auscultation. So it's a very good screening in your clinics to pick up patients with heart valve disease. And that's how she was diagnosed. The doctor heard a murmur and then sent her for an echocardiogram. And you can see that in the echo there is very severe mitral regurgitation. She then went on to transesophageal echocardiography. You can see there are actually 3 jet lesions. So she has 3 different lesions causing the mitral regurgitation. Now she has a few options. You can control her with medications, with diuretics, with spironolactone, with some ACE inhibitors or ARB blockers. This will help her feel better. This will improve her quality of life. But you would not have solved the underlying problem, and it's only a matter of time before it progresses again. And the only definitive way to treat this is by surgery to repair the valve, or in most cases, and in sometimes to replace the valve if we are unable to repair it. So in the patients treated medically, you can see over 10 years, 30% would have gone into atrial fibrillation, 60% would have gone into heart failure, which you can't control with medications. 80% would have required surgery because of failure of medical treatment. 90% would have either had surgery or would have died. So within 10 years, these patients would have needed surgery because medication alone would not have been sufficient to control their symptoms. But the earlier that you do the surgery, the better their survival. This is data from the Cleveland Clinic looking at 4,000 patients at what stage they had surgery. So you can see that patients who had surgery when they had no symptoms but were diagnosed with severe mitral regurgitation, they lived the longest compared to patients who had surgery when they had mild symptoms. And if you wait until the patient has severe symptoms, then their survival is the lowest, even with surgical treatment. So the patient went for mitral valve repair surgery, and this is echo after surgery. You can see good coaptation between the leaflets, and there was no mitral regurgitation, and she is now well and asymptomatic. The operative risk of mitral valve repair surgery is about 1%. They stay about 5 to 7 days in hospital. After 1 month, they can drive again. They're quite okay. The full recovery is between 2 to 3 months. After valve repair surgery, they still need to be on some antiplatelets for about 6 months until the tissues are fully endothelialized, and they can stop the antiplatelets. It's important to control their heart rate and blood pressure to ensure the durability of the valve repair so as to lessen the strain on the mitral valve. And if the heart is already dilated, you can promote reverse remodeling by giving them some ACE inhibitors or ARB blockers. Important also to remember that these patients need dental prophylaxis, antibiotic prophylaxis for any invasive dental procedures. Even though there's no artificial valve, there's still some artificial material in there. So if they need invasive dental treatment, they should still have antibiotic prophylaxis. So for the mitral valve repair is the best because it's your own tissue, it's good durability, there's no need for anticoagulation. But of course, in a small proportion of patients where it's not possible to repair the valve, then they can go for a valve replacement with the advantages and disadvantages we discussed earlier. If we're able to repair the mitral valve, we actually restore their life expectancy back to normal. So this is a study from the Mayo Clinic showing that those who had the valve repair had the same life expectancy as a normal patient, a normal healthy patient. So that's why valve repair is better. If we have to replace the mitral valve, we do not restore life expectancy back towards normal, but we still improve their life expectancy. There are different techniques to repair the mitral valve. We can do some leaflet resection to restore it to its normal shape and size. We can put in some artificial cords to replace ruptured cords. We can put in a ring to restore the size and shape of the mitral annulus back towards normal. Now, this is another case of a 29-year-old lady. She had complained of fever, headaches, and reduced exercise tolerance, and was admitted to hospital with septic shock. And staph aureus was grown from blood cultures. And you can see this huge vegetation here on echocardiogram. Now, the risk of this is that it would embolize and cause a stroke. And if it embolize elsewhere, it would cause a source of sepsis with abscess formation elsewhere. So once there's vegetation more than 1 centimeter in diameter, we would recommend it be removed. And this is her transesophageal echo. You can again see the vegetation, and she also has at least moderately severe mitral regurgitation. So at surgery, you can see this huge vegetation, which was very fragile. She was very lucky that she didn't have a stroke, so that was removed, and everything was cleaned up. You can see a huge hole now in the commissural leaflet of the mitral valve, which fortunately could be repaired, and she had a good result. She then went back to the referring hospital to complete the 6 weeks of intravenous antibiotics. It's important that these patients, even after surgery, they need to complete their 6 weeks of intravenous antibiotics to prevent a recurrence of the infection. This is another case, a 29-year-old man from the KL region, and he had persistent fever despite antibiotics. Staph aureus also was grown, vegetations on the mitral valve, and even if 2 weeks of intravenous antibiotics, he was still pyrexia, inflammatory markers were still high. And you can see the reason why. There was all these vegetations in the mitral valve, which had also eaten away the large part of the mitral valve. So in this patient, it was not possible to repair the valve because it's been almost destroyed with staph aureus. So he had to go for a valve replacement. And he's made a good recovery, but he has to learn to take warfarin because at that age, we put in a mechanical mitral valve. This is mitral stenosis. Usually in cases of mitral stenosis, it's not possible to repair the valve because, as you can see, it's all fibrosed and calcified. So in most of these cases, we have to do a valve replacement. Now, as with the aortic valve, we can repair the mitral valve through transcatheter means. We can put in a device through the femoral vein, cross the atrial septum, and then clip the mitral valve together. It's called a mitral clip. It doesn't work for all cases, but in certain patients, it can work. It can certainly reduce the severity of the mitral regurgitation. But again, if we look at the results, the effectiveness of this treatment. So at freedom from death, mitral repeat surgery or mitral valve intervention, the red line is those who have conventional mitral valve surgery. The blue line is those who have this new device implanted. So the freedom from death or reintervention is much higher if we have surgery compared with this device. So this device is still not routinely used because it doesn't give as good a survival as surgery. But for those who are unfit for surgery, then this is an option because it's still better than just taking medications. And this is the COAPT trial where they compared the device called the mitral clip with medical treatment. So it is better compared to medical treatment, but not as good as conventional surgery.